right. I'm Matt McCrary. I'm part of the InFocus research group, which is primary investigators David Goldstein and Susanna Park. And our research group looks at chemotherapy-induced peripheral neuropathy. And presentation today is on a project that our group runs, looking at feasibility and sensitivity of a CIPN questionnaire, specifically looking at benefits of electronic assessment. So here we go. So a bit of general background on chemotherapy-induced peripheral neuropathy. First off, what is it? It's a debilitating side effect of cancer treatment that may occur when chemotherapeutic agents damage the peripheral nerves outside of the brain and the spinal cord. And so this is becoming more and more relevant given that there are 28 million cancer survivors worldwide, and over 50% of these cancer survivors have survived colorectal, breast, ovarian, lung, or hematological cancers and are at risk for CIPN due to their treatment with neurotoxic agents such as taxanes or platinum-based chemotherapy regimens. CIPN reduces treatment tolerability, often leading to dose reductions and treatment cessations, and it also produces long-term deficits ranging from mild tingling and numbness in the hands and feet all the way to full functional disability and even falls. There's currently no method to identify at-risk patients for CIPN. Quantitative and functionally relevant assessment tools are lacking, and that's the point that our project centers on, and also there's no effective neuroprotective strategy for CIPN. So a bit more information on assessment tools for CIPN. How is it assessed? Most commonly assessed by clinician-based grading scales, such as the NCI, CTCAE, which I've shown here on the bottom. It's very quick and easy to use in the clinic, 0 to 4 scale, 0 being no neuropathy, 4 being disabling neuropathy, and then graded in between. However, research has shown that this scale lacks inter-rater reliability, objectivity, and sensitivity to change. Additionally, clinicians frequently underestimate and inconsistently grade the severity of CIPN, and also these clinician-based grading scales may underreport the severity of CIPN compared to patient reports. And patient reports are the second main category of CIPN assessment tools. They're not systematically utilized in clinical settings due to some barriers, which is what this project is trying to address. However, patients do identify CIPN onset earlier than clinicians on these patient-reported outcomes surveys, and there's better agreement between patient and nurse, although not between patient and clinician rating of CIPN symptoms. And as I mentioned, not systematically used in the clinical setting due to some barriers to efficient integration. And one means of looking at overcoming this barrier has been using electronic tablets to use electronic tablets as a delivery method for patient-reported outcome surveys. And a bit of background on the tablets here. So tablet and paper-based survey assessments have been shown to be equivalent in chemotherapy patients, also highly feasible and even preferred to paper-based assessments by patients. And also they're unsurprisingly correlated with a lower percentage of missing data compared to paper-based assessments. That said, the feasibility of tablet-based survey assessments has never been verified in a CIPN population before. And just one more bit of background here, looking just more generally at electronic medical records and CIPN reporting. So peripheral neuropathy has been recently included as part of the pre-treatment assessment, which is this box that I've screenshotted here on the right, as part of the Mosaic electronic medical record system, which is in use at Prince of Wales Hospital. And this is not a mandatory input. However, at each cycle of chemotherapy treatment, there is a box for peripheral neuropathy where usually the nurses can go in and input the peripheral neuropathy grade at the time of their chemotherapy treatment. And the question here is, does electronic medical record systems such as this affect the frequency of CIPN reporting compared to paper records where clinicians and nurses often have to free write grade 1 neuropathy or neuropathy affecting function, having some sort of tool like this. So with that background, we had following 3 aims. The first was to determine the feasibility of a tablet-based collection method of patient-reported outcome data in patients receiving neurotoxic chemotherapy. The second was to compare CIPN reports of patients versus clinicians. And finally, to determine the frequency, detail, and authorship of CIPN reporting during treatment and follow-up in a hospital setting, and specifically looking at a comparison between electronic and paper records. So the methods, how we looked at attacking feasibility in the first two aims is we took patient-reported outcomes questionnaires on an iPad, and we administered them in the waiting rooms of oncology clinics on the Prince of Wales Hospital campus. The patient-reported outcome questionnaire we used was the CIPN-20, which I'll give more details on the next slide. And we had a 10-point feasibility scale at the end of the survey, in which patients were asked to answer the question, how easy was it to answer these questions using this iPad on a scale of 1 to 10, with 1 being not easy at all and 10 being extremely easy. Patient scores from the CIPN-20 were then compared with clinician grading appearing in patient records at the time of questionnaire administration to look at patient versus clinician grading of the neuropathy symptoms. So this is the CIPN-20 questionnaire. Just briefly, it's a 20-question patient-reported outcome questionnaire in which patients are asked to indicate the extent to which they experience the following symptoms over the past week on a scale of 1, not at all, to 4, very much. And this scale can be broken down for analysis purposes into a sensory subscale, a motor subscale, and an autonomic subscale. And the final bit that we did was we analyzed chemotherapy grading in medical records obtained from all chemotherapy cycles and follow-up appointments for our entire patient cohort. And we were looking at 3 main things here. The first was the content of the report, specifically whether or not a neuropathy grade was included in the report or if it was just a general description of neuropathic symptoms. Secondly, we looked at the location of the report. So where was the report? Was it in the clinical notes, oncology flow sheet, clinician letters, or electronic or paper adverse event assessment forms? And also looking at whether there was an electronic or paper medical record for each patient. And third and finally, the author of the report, was it the clinician or was it the nurse? So we recruited 29 participants, 23 females and 6 males from October 2015 to April 2016. Mean age of the cohort was 57 with a range of 27 to 81 years. 20 were treated with taxanes, 9 with platinum agents, 11 early treatment, 3 mid-treatment, 8 late treatment, and then 7 patients in post-treatment follow-up. So the results, feasibility of the tablet was quite high in our cohort with a mean ease of use of 9.42 out of 10 and only 1 rating below 8 out of 10. And additionally, 90% of patients over 60 years reported a feasibility of 9 or 10 out of 10 with a mean ease of use in this cohort of 9.7. So it appears to be feasible across ages. And also critically, there's no change in feasibility with increasing CIPN grade. So the tablet-based delivery method was not less feasible for patients with more severe neuropathic symptoms. Now looking at CIPN grading, so specifically the comparison between patient reports and clinician grading. So 55% of patients reported tingling or numbness in the hands or feet, while only 21% of clinicians graded patients as presenting CIPN symptoms at the time of tablet survey administration. And one thing I want to point out as well is there looks to be a difference between early and late treatment in terms of the severity of neuropathic symptoms. And this makes sense based on things that we already know about CIPN, specifically that it follows a dose-response mechanism. So after a certain neurotoxic threshold dose, which for taxanes is 300 milligrams per meter squared, increasing dose leads to increased severity of neuropathic symptoms. And the CIPN-20 patient-reported outcome questionnaire does appear to be sensitive in picking up those changes correlated with dose. And so finally, looking at the general CIPN reporting trends in the patient medical records. So now we're looking at across all chemotherapy cycles. So neuropathy status was reported in patient records for 75% of analyzed cycles of chemotherapy, and 92% of these reports included a grade for CIPN. That said, there was a large variation in the frequency of CIPN reporting for individual patients, ranging all the way from 0 cycles to 100% of patient chemotherapy cycles. There's still a large variation in how often CIPN gets reported on. Chemotherapy always gets reported. So the author of chemotherapy reports and grades most commonly was the nurse in about 70% of cases, was the clinician in about 26% of cases, and then unclear authorship basically just means we could not determine what the signature was on the patient in the patient record. And finally, looking at paper versus electronic records. So 11 patients were in patient records, or were in paper records, and 18 patients had their information in electronic records. And you can see that there's a higher percentage of chemotherapy cycles where the CIPN grade was reported in patients who were on electronic medical records compared to those in paper records. And our theory is that that's due to that pre-treatment assessment tool, that it's just very quick and easy to input information regarding neuropathy, and that is a significant difference, P minus. So, wrapping it all up, 3 aims, bit of stuff going on here, so I'll just wrap up. First, electronic tablet-based survey assessment is feasible in patients receiving neurotoxic chemotherapy. Second, patient-reported outcomes are sensitive to increasing neuropathy, and they're also linked to cumulative dose, although they don't necessarily correlate with clinician grade. Third, neuropathy reports existed for 75% of chemotherapy cycles, with the nurses most frequently reporting on CIPN symptoms, and CIPN grading more frequently recorded in electronic compared to paper medical records. And so basically what this all means is, and the future view of this is that tablet-based survey approaches may provide a suitable means to assess the significance of CIPN symptoms using patient-reported outcome surveys in the clinic, and there's definitely some scope for integration of tablet-based PRO collection methods with electronic medical records in real time. That's where we're looking to head with this in the future. In the immediate future, this is an ongoing project. The PRO CTCAE, so it's a 4-point grading scale, but a patient-reported outcome version, has recently been updated to include neuropathy, and this enables us to provide the first apples-to-apples comparison of clinician versus patient neuropathy grading, and also to correlate this with other common PROs that don't use the same 0 to 4 grading scale. And we're also looking to have a more targeted collection of patients in later stages of a treatment, so we have an increasing, a cohort of patients with increased severity of neuropathy. And yeah, just acknowledgements here. This project was supported by Cancer Institute New South Wales Translational Program Grants. Many thanks to the Cancer Institute. Thanks to InFocus investigators, participating patients, Prince Wales Hospital and Royal Hospital for Women, and then these 4 clinicians who allowed us to access their patients, Michael Friedlander, Craig Lewis, Mark Hertzberg, and Kate Weber. Thank you very much.